Good evening, dear doctors. I'm Zeena Chauhan from G Healthcare. On behalf of G Healthcare, I welcome you all to another clinical episode on our XP Connect webinar education series powered by Voluson technology from G Healthcare. Fetal heart is a significant focus in pregnancy management as the detection, diagnosis, and the management of congenital heart disease is of primary importance. Every parent needs to know if their baby has heart defects as early as possible. Voluson Expert series are equipped with the tools that supports the evaluation of fetal heart. Today, we have one of our best speakers in the field of fetal medicine, Dr. Chander Lulla. It's my pleasure to introduce him to you. Dr. Chander Lulla is a consultant and fetal medicine specialist at RIA Clinic, Mumbai. He also heads Department of Ultrasound at Jaslok Hospital, Mumbai. He is also consultant ultrasound department Reliance HN Hospital, Mumbai. He has published and presented many papers and lectures at various Indian and international conferences and journals and also contributed to the books. He is currently Dean of IFUMB and held many prestigious positions in the past, like he's the ex-president of IFMUB, ex-counselor of EPSAM, ex-editor of IFMUB General, ex-ISWAG ambassador for India. With this, now I will hand over to Dr. Chander Lulla to begin his talk on fetal cardiac evaluations with fetal HQ. Over to you, sir.
Thank you, Zenith. It's a pleasure to be back with on the GE-XP webinar again. The topic we have selected today is fetal cardiac function. And as you can see here, many of our babies land up in the ICU with situations like this. And this is what we want to always avoid and see that we don't have these situations. So before we talk on fetal cardiac function, I hope everybody is safe and doing well in their practice as everybody started working. And just to remind about fetal circulation, we know that there is a right-sided dominance of the fetal circulation. And majority, that is 60% of the cardiac output goes through the right ventricle into the systemic circulation via the foramen ovale and the ductus arteriosus. So basically in the fetus, the right ventricle is the systemic ventricle. And the fetal circulation is unique because it runs in parallel, both the right side and the left side, and they communicate, as I said, through the foramen ovale and the aortic isthmus. But basically, we have two parallel circulations, and each can get affected by different pathologies. So it's very, very important to study the fetal heart on both the sides. Now, just to remind us, we always look at the heart, and in early days, we used to always say the squeeze is good or bad, and that's how we used to evaluate cardiac function. It used to be a cursory evaluation of the heart, and nobody would really look into nitty-gritties as we are doing now with a lot of detailing. So when we look at the fetal heart and the entire cardiac cycle, it's best seen when we put the Doppler across the mitral valve, and we can see the E to A wave of the mitral inflow and the ejection of the in the aorta. And so we compartmentalize this single wave into an early phase where the E wave stops and the ejection has not yet opened up. That means diastole the valves are closed, the heart is contracting against the closed semilunar valves, and then the semilunar valves open and the blood flows out into the aorta, and that is the ejection. And then again, at the end of peak systole, the heart relaxes with the valves all open, and that is called as the relaxation time here, as you can see, IRT for short. The first measurement is the isometric contraction time, where the heart is contracting against closed ventricles, and this is the ejection time. So this is the entire cardiac cycle which we see here. So the systole is comprised of the isometric contraction time and the ejection time, and the diastolic phase is represented by the isometric relaxation time and the atrial filling, which is the early E wave, and the atrial systole, which causes the late ventricular filling. So this is how we compartmentalize the systolic and diastolic components of the cardiac cycle. Now, what is the function? Cardiac function is the ability of the heart to provide appropriate cardiac output in a sustained fashion throughout the fetal life. And it should also be able to adapt to changing circulatory demands. Whenever there is anemia, the fetus pumps more so that it makes a hyperdynamic circulation. So this adaptation process is very important, and it is relevant to the myocardial contractility. Now, there are various diseases like fetal growth restriction, diabetes mellitus, obesity, TTTS, etc., which can adversely affect the heart, and not only in a severe fashion, but very early affection, and also it can cause irreversible changes for presenting as diseases of adulthood, the typical Barker's theory. So there's cardiovascular and CNS remodeling. We know that. And that's why we need to evaluate cardiac function in various pathologies. Deterioration of the function may often be the first sign of pathology, or it may be the end sign, but it could be an early sign which we may not detect with regular conventional methods. And we may need to monitor cardiac function over a period of time, so temporal tracking, so as to allow interventions and other management decisions, as we have seen in IUGR, etc. We look for the ductus venosus reversal as a sign of diastolic dysfunction. So that we need to develop very sensitive markers or methods of quantifying cardiac function so that we can pick up early cardiac dysfunction and not have late detection of cardiac dysfunction. Now, what are the important factors which affect the cardiac function? We know that there could be an intrinsic cardiac problem. This could be a structural or a functional heart disease, something like cardiomyopathy, or it could be an arrhythmia, and these can affect the cardiac function. We could have extra cardiac causes, volume overload due to increased venous return, specifically in TTTS. You could have a hyperdynamic circulation like anemia or AV malformation. You could have cardiac compression by congenital diaphragmatic hernia or lung tumors. And of course, increased afterload due to increased placental resistance in IUGR, and maternal diabetes can affect the myocardium. So these are basically all the causes of cardiac failure. You could have low output failure due to a cardiac defect, essentially. High output cardiac failure due to an hyperdynamic circulation. You could have, sorry about this, you could have a venous, lymphatic or venous obstruction causing cardiac obstruction, specifically the chest tumors. And of course, there are some idiopathic causes like chromosomal abnormalities where there is increased capillary permeability and volume overload on the heart. So these are various causes, and these are some of the common causes where on a day-to-day basis we may need to evaluate the fetal cardiac function, especially maternal diabetes, as we know, affects the heart. You could have IUGR, fetal anemia, and a host of congenital abnormalities. Now, typically, the cardiac dysfunction goes through these stages. Just like IUGR, initial stage is a chronic adaptation stage. Then there is subclinical cardiac dysfunction, and finally cardiac failure, as we see in all the stages of IUGR. Now, the only problem here is that the contraction of the myocardium is a bit complicated, and we'll talk about that. There can be various muscle fibers which run in various directions, and therefore a lot of modalities have been used in the past to understand the cardiac function, being M mode, conventional pulse wave Doppler, tissue Doppler, and now on the horizon are new modalities like Speckle Tracking. So we'll look into all these theories. Now, here is a schematic diagram of a very, very complex process, that is the myocardial disposition in the heart. It's not as easy as that, and it's very simply described as a pretzel theory to suggest that the fibers run in all directions. So essentially, the right ventricles during systole, there is contraction of the fibers in a longitudinal direction, whereas the left ventricle contracts both in the longitudinal and circumferential direction. And this essentially causes, therefore, contraction in the form of thickening, shortening, rotation, twist, and torsion. Now, it's not possible to measure all these modalities, but we have to do some justice to coming to a conclusion. So in the past, this has been the way we have been looking at cardiac function. The systolic function, we would look at systolic function separately, diastolic function separately, and then of course there are tools which look at global cardiac function. The primary interest of looking at cardiac function is, of course, always looking for cardiac output. That is the output of the aorta per unit time. But it's a very, very difficult method of calculating cardiac function, and we'll look at that. So we use what is called as the ejection fraction. That is the relation of the end diastolic volume minus the end systolic volume divided by the end diastolic volume. We multiply by 100 and it's usually 30 to 60%. So ejection fraction is essentially a surrogate marker for measuring the cardiac output. And like I said earlier, we'll use M mode, we can use spectral Doppler, color Doppler, and of course now we can use Speckle Tracking. The diastolic function of the heart is essentially looked at across the AV valves, across the mitral valve or the tricuspid valve. We look at the EA ratio, and as I said earlier, the isometric relaxation time on the TI index. And then, of course, we have a myocardial performance index, which looks at global cardiac function. And we'll look at that a little bit later. So two components affect the cardiac function. One is the preload, that is the venous return on the heart. As I said earlier, various factors can cause increased venous return or compression of the venous return, like a cardiac tumor, and this can cause preload alterations. Then you can have afterload in the form of placental resistance. So the heart is pumping against a resistance, and because of which there is increased afterload. And of course, inherently, the contractility of the heart can dictate the ejection fraction to be altered. So the systolic velocity is usually affected by the afterload and by the myocardial contractility, whereas the end diastolic volume is affected usually by the preload. So this is the compartmentalization of the two. So what do we measure? We measure usually the ejection fraction in an adult heart, and we translate that into the fetal heart. Now, as we know, the Simpsons rule of measurement of stroke volume or the ejection fraction has been used in adult and pediatric life, and that is assuming an ellipsoidal shape of the left ventricle. Now, we know that the left ventricle is not completely ellipsoid. But on a four-chamber view, it very typically looks like an ellipsoid. Similarly, the Simpsons method is based on a biplane calculation. So it is a 2D calculation on a biplane, and we know that the heart is a 3D structure. But to simplify it, the stroke volume or the ejection fraction is calculated from the left ventricle by the Simpsons rule. So left ventricle, the ejection fraction serves a good purpose to measure it. Now, the problem comes the right ventricle, because if you see in this cross section, the right ventricle is typically triangular and crescentic in shape. It is not ellipsoid in shape. So we cannot use the Simpsons rule to calculate the ejection fraction. So essentially, we calculate for systolic function the ejection fraction of the left ventricle, and on the right side we use a fractional shortening, that is in longitudinal fiber shortening, or we use the transverse contractility, we can measure the transverse contractility, or we use fractional area contraction, and this is what we'll talk about a little later. So this is the appearance of the left ventricle, and you can see that if you view from the apex, the base is contracting in a clockwise direction and the apex is contracting in an anti-clockwise direction. So it's a very complex structure, and we just use simplified measurements to simplify what we can do. So a sarcomere, that is a muscle shortening of 20%, produces an ejection fraction of about 60%. And that's important to remember, because the normal strain in the heart, that is the ability to contract, is about 20%. So if the strain is 20%, the ejection fraction will be 60%. And That is what we are looking at when we measure the heart. Now let's look at some traditional methods of measuring the fetal cardiac function as an introduction to understand it. So the M mode essentially is used across the interventricular septum in a four-chamber view, and we look at the diastolic diameter and the systolic diameter, and from it we calculate the ejection fraction or the shortening fraction. As I said earlier, this is the end diastolic ventricular diameter minus the end systolic diameter upon the end diastolic diameter into 100, and that's usually about 34% plus minus 3%. So very, very simple method. The only problem is that this is essentially a late event. So when the heart is really enlarged, will we see changes on the M mode? And again, it is angle dependent. So you have to have a perpendicular disposition of the M mode across the interventricular septum, and therefore you need a view like this. Now again, here you're only measuring contraction in a particular segment of the heart, and you're only measuring transverse contractility. So to measure longitudinal contractility, you would have to measure in this direction. And that is what we use when we measure the TAPSE, or the tricuspid annular phase systolic excursion. So when we want to measure the longitudinal function, as I said earlier, the right ventricle has predominantly longitudinal contractility. The left ventricle has longitudinal and transverse contractility. So we place an M mode cursor across the tricuspid annulus and we look at the excursion, and this excursion varies with the period of gestation, going from 3 millimeter to 8 millimeter, and anything more than 8 millimeter to 10 millimeter is considered as abnormal. Anything less than that is considered as abnormal, because the heart would therefore not be contracting in a longitudinal fashion. And here, as you can see, but again, here you see a severely hydropic heart, and you can see that if you put an M mode here, you will get a good movement. So it's not a very sensitive criteria. It's a late criteria for measuring cardiac dysfunction. And in today's era, where we are looking at in utero correction of cardiac disorders or early management or management with better output, I think TAPSE is not really a great method anymore. So, and of course, it is a one-dimensional measurement, as I suggested earlier, for a complex three-dimensional structure. Then came the use of pulse Doppler, and of course, we can measure volumes, and therefore this was of great interest to measure the cardiac output, as I said earlier. So cardiac output was the stroke volume into the heart rate. So we could measure the volume dependent on the diameter and the peak systolic velocity, the mean velocity, and then multiply the heart rate, and therefore we would get a cardiac output. But here again, there could be a lot of errors in measurement, because it's a small vessel you have to measure, and the heart rate may vary, causing the cardiac output to vary. And also you cannot get a good, Doppler is angle dependent, and here you have to have an appropriate 30 to 60 degrees. Again, this is a late event, angle dependent, and there's a lot of variability. But Doppler is useful to look at regurgitation, that is represented as the systolic function. So whenever the heart contracts, the valves leak and you will get regurgitation. If there is significant tricuspid regurgitation throughout the cardiac cycle, more than 70 milliseconds, we know there is cardiac dysfunction, right ventricular dysfunction, or systolic dysfunction. And of course, if there is mitral regurgitation along with tricuspid regurgitation, we know that the heart is in serious trouble. There is systolic dysfunction, and this heart is already enlarged, and you can see how bad this heart is. So this is again a late feature. It is angle dependent, and it's useful when we have hearts like this. Now, a marker that we have been using regularly is, of course, the venous Doppler, and that is the ductus venosus. And we all know that reversal of the A wave is a good marker to suggest that the heart is failing in diastole. So when the heart, the atrium contracts, instead of having forward flow, there is regurgitation or leak in the reverse fashion, and causing a reversal of the A wave, suggesting that we have early diastolic dysfunction in the heart. And we use this as you have seen in the truffle study and in early IUGR, to time our delivery. That is, if there is ductus venosus reversal, we can use this as a marker. But of course, this is again a late marker. The heart is already seriously in trouble by this time, and therefore it can be a little tricky. The diastolic component of the heart, as I said earlier, we look at by looking at the inflow into the heart during diastole. And that's where we put a Doppler across the mitral valve and look at the E to A wave ratio. And this is normally about 50%, 50 to 60% in the early part of pregnancy. Normally, the E to A wave, there is reversal in the late part of pregnancy. But if there is a cardiac dysfunction or an early diastolic dysfunction, you can get a drop in the E to A ratio, as you can see in a recipient with TDTS, and you can see an increase in the E to A ratio in IUGR, as you see here, because the E wave, the filling during the early wave, is more as compared to the atrial contractility, which is effective. So here we have a dilated heart, and you can see that there is reversal of E to A wave. And this can be seen in IUGR in various other conditions which can cause cardiac dysfunction. Again, it's a Doppler technique and it is angle dependent. If you don't have the appropriate Doppler angle, then it can have erroneous results and you can have a lot of variability. And also, if there are conditions where the heart rate is high, you may have a monophasic pattern of flow in the rather than a biphasic pattern, and this may again be a false positive. It is, of course, a poor prognosticator where the heart is severely diseased if you get a monophasic pattern, as you see here, because there is very minimal filling in diastole in the heart. Then we have a Doppler which can be used to calculate the myocardial performance index, and that is called as the TI index. And as I explained earlier, we have the contraction time plus the relaxation time above the ejection time. And this is by far the single best Doppler technique or method to measure global cardiac function. So you're measuring both the diastolic and systolic component. ICT is a systolic component, IRT is a diastolic component, ejection time is again systolic component, and the ratio of all this put together gives us an idea about global cardiac function. And this is very good to measure both systolic and diastolic function independent of cardiac structure, and you can use each ventricle independently. And it is independent of cardiac rate and function. So it's like the ESR that we use for looking at various diseases. And the myocardial performance index increases due to various components getting altered in various conditions. For example, in infection, there is a rapid heart rate, shortening of the ejection time, and again, the TI index will increase. In TTTS, the recipient twin, there is prolongation of the diastolic time because of diastolic dysfunction. So IRT increases, therefore the TI index increases. We can have hydrops, BARTs, anemia, and even diabetes, all causing increase in the performance index or TI index. And so also in IUGR, the IRT, the relaxation time increases, and therefore in the early phase and in the late phase, even the systolic component is affected when there is severe cardiac dysfunction, and again the TI index is increased, and it has a direct correlation with fetal death. So here we have two instances of the same fetus here with absent diastolic flow initially, and there's good duct flow in the ductus venosus, suggesting that there is no diastolic dysfunction. And follow-up after a period of time shows that the ductus venosus is yet showing normal flow, but the isometric relaxation time is increasing. And this is one marker which is very sensitive to tell us that there is early diastolic dysfunction of the heart. So normal MPI being 0.5 to 0.6, and you can see that in a matter of 20 days, the MPI has increased from 0.73 to 0.90, and yet the ductus venosus is showing normal flow, suggesting that there is early cardiac dysfunction, and if at all any management decisions need to be made, you could do it. In fact, IUGR is one condition where we can look at various components of the heart affected. So there is increase in peripheral resistance causing increased afterload. The hypoxemia causes myocardial contractility disturbances, so it impairs myocardial contractility. And because of increased viscosity and polycythemia that we see with IUGR, this may alter the ventricular filling. So all three components are affected, and you will therefore have increased loading of the heart, and this will cause an alteration in the shape, early cardiac dysfunction. These are sequential changes, just like you see on Doppler in early IUGR. These are sequential changes in the heart. You will see early diastolic dysfunction, that is reversal of the E to A ratio. Then you will have prolongation of the isometric relaxation time. And finally, the heart will fail overall, and you will have lower TAPSE, that is the longitudinal contraction of the annulus and the tricuspid valve, and then you will have both mitral and tricuspid regurgitation. And then, of course, the ejection fraction will get disturbed, the cardiac output will be disturbed, and you will have reversal also in the ductus venosus. So IUGR is one of the methods to study the heart very, very closely. Now, what are the new methods of studying the heart? I must confess, I started studying the heart as early as 2009, 2010 with a very, very primitive strain analysis machine, the vector velocity imaging. And finally, today we have progressed thanks to GE and thanks to Gregory DeVore, I think, who has done the massive amount of research and made us understand everything that we were doing in the last 10 years with cardiac function analysis. So let me go through this. And this was really my first case. I just have sentimental reasons to show it. This was a fetus almost at 34 weeks with a globular heart. And for some reason, I switched on tissue Doppler imaging, and we could not get signal in the apex on the left side. And that's just a normal heart showing you a good global color in the fetal heart all through and through. Taking that further, of course, we put a Doppler, and we could see reversal of flow in the ductus venosus here. And as you can see here, that same segment, there was severe mitral and tricuspid regurgitation. She was 34 weeks, and she had only had an anomaly scan done before that. So obviously the heart was very, very bad. And because we saw this segment, we were not sure whether this is an ischemic non-contractile segment. We had access to Speckle Tracking, and we tracked the endometrium at that point of time. And when we track the endometrium, you can see that the blue dot is kept on the normally contracting interventricular septum, and the red dot is put on the area which was not contracting, and that is represented here. You can see the interventricular septum contracting very well, and the apical side was not contracting. So this was very segmental ischemia, which I saw early in 2010, and I realized that there are portions of the heart which may not be contracting as compared to the entire heart not contracting. So it's not always a completely global phenomenon. And that's why we got interest in doing speckle tracking. So speckle tracking is a non-Doppler technique. You put markers on the endocardium and track it over a period of time, and this will give us a lot of information in the form of strain. Strain basically being what is the contractility of the endocardium. So endocardium, as you know, is most sensitive to lack of oxygen. And if there is ischemia, the endocardium will stop contracting, and this is what we hope to see with speckle tracking, and as we'll talk about. It used to take a lot of time with the early software, and GE has simplified it to such a great degree that I think it doesn't take me more than even 2 minutes to perform this technique. You have to basically put 3 points, as we'll show you, and then the machine does all the calculation. To give you an insight into what is strain and strain measurement, basically this is the endocardium speckle which we highlight in diastole, and it moves during systole to an inward area. And whenever we put the dot, we track in diastole and systole, and the machine tracks it, and automatically it tells us where was the position and gives us the strain, as we can see here. So in end diastole, the myocardium is an appropriate length, which is the normal length. It contracts in systole, and it contracts in systole, and so if the initial length is about 10 centimeters, it will become 8 centimeters in systole, and you can see therefore, and then it relaxes to a full length of 12 centimeters, and therefore the difference is about 2, as you can see, 8 to 10, and this is a 20% difference, and therefore the strain is 20%. So depending on how much the sarcomere or the myocyte contracts, if it contracts to 7, your strain will be 30%. And essentially, a systolic strain, that means when it contracts, is considered as negative strain, and when it dilates, we talk about it as positive strain. So this is the basic principle of strain. And then we look at strain over a period of time, and that is called the strain rate. So this is documented in this algorithm here, as you see. So strain is the deformation of an object relative to its original shape. The speed of this deformation is called a strain rate. And then we can track the movement of the myocardium, or the velocity of the movement, and how far the distance that it moves is called as displacement. So these were the early parameters that we were looking at. And here you can see that myocardial strain can reflect the changing physiology of the fetal heart. So what we used to do, we used to take a measurement and track it along the endocardium. And this was a very, very primitive method. We used to rely on our vision to see that we are doing a good job. And from this, we would get the vector as you can see here. So there was no accountability here. This was very subjective. We had to rely on our expertise. And it took me a lot of time to really develop expertise and to see which positions of the heart you get good vectors and which not. And then, of course, in the year 2015, Gregory Devore, we started seeing his papers. And initially, I couldn't understand in some positions why we were not getting a good vector, till he did some large number of studies and established the fact that just like we see the apical view of the heart, we may get a dropout here. The endocardium is not very well appreciated in that view, and it is better appreciated in this slightly oblique or lateral view. Of course, as you see in the right corner here, this is the best view to track the endocardium because you can see globally the endocardium very well. So these are the three preferable views: apical upwards to the left with the left ventricle going to the left side, lateral view, and posterior view, oblique view. What is not preferable is the apical forechamber, anterior or posterior, because that does not show a good endocardium. Essentially, why is that? Because we need to track the endocardium, so we need a good forechamber view without foreshortening or misleading appearance of the endocardium. So in the year 2010, we did a very, very early study of about 50 cases, 25 normals, and we established what is the normal values that we should be looking for, and this was published in 2018. So the normal strain that we were seeing in the fetal heart in various gestations, of course, was -10 to -20%. The ejection fraction, as I said earlier, was 35 to 75%. And these was a very simple paper. And then we also looked at few abnormal cases. And you can see that a normal strain being -20 in abnormal situations, at times it was as low as -6. The deformation over a period of time also we measured, and this was also very, very low in cases of cardiac abnormality. And we'll, of course, look at that. But all this has become very, very simple with the GHQ. And I'm just wondering why we wasted our 10 years and why they took so much time to make this technology. So with HQ now, we can look at global and individual ventricular size, shape, and contractility. We can look at global size. We can look at each ventricle size. We can look at the sphericity index. As you know, in certain situations like in IUGR, due to increased afterload, the myocardium gets hypertrophied and the heart becomes more globular. So the GSI alters, and we'll talk about that. And then, of course, strain and fractional shortening, or which is again, like I said, is a surrogate marker for the ejection fraction. So we actually looking at the shortening in systole and diastole. A little word on the global sphericity index. It is the ratio of the four-chamber length and the four-chamber transverse width. And normally this ratio is about 1.1. It is telling us that the heart is becoming globular in certain situations, which is oxygen deprivation situations. A normal cutoff is 1.1. And if this ratio increases, then we know that the transverse diameter is increasing, and therefore you will get abnormal ratios in that particular situation. So it's a very, very simple technique to measure. You measure the longitudinal diameter and you measure the diastolic diameter. You don't really have to measure. The machine does everything. You just place the 4 points and this will give us the diameter. So as I said earlier, the fetal heart in IUGR changes because of pressure overload. There is ventricular hypertrophy. There is volume overload because of polycythemia, and you can have ventricular dilatation. And in an attempt to maintain the stroke volume, you have myocardial dysfunction. And all this leads to a shape alteration, and the GSI falls below 1.1. And that is a very, very important sign. So that is looking at global sphericity index. And we thank Dr. Gregory DeVore for this wonderful analysis of each segment of the heart. So he divided each ventricle into 24 segments. So from the apex to the mid portion, from the base to the mid portion to the apex, and each segment after being tracked by the HQ would automatically give us the sphericity index in each ventricle and in each segment of the heart. And this is very, very important. As I showed you earlier, at times early dysfunction may not be global. It may be segmental, as we saw in our case, and a particular segment of the heart may be altered. So if you get segmental alteration in a particular segment, we know that there is cardiac dysfunction in that segment, and that's an early dysfunction. Now, the normal GSI in each ventricle, each segment is about 1.8, and if it decreases, then we know that there is cardiac dysfunction. Now, it's very cumbersome to look at 24 segments, although I must congratulate him. He has actually done this humongous work, and in subsequent papers, he realized that if you look at segment 1 and 12, this is as good at looking at all the 424 segments. So if you are doing HQ, you will realize that when you look at the report sheet, it today gives us segment 1 and segment 12. And once you identify a segment with poor function or sphericity index, then you can do a detailed evaluation of the heart. The next important principle that you have to look at is the speckle tracking and the strain analysis. Now here I must point out again that this animation is very, very important. Like I told you earlier, in the earlier days we were looking at our own instincts to plot the endocardium. And we had to rely, it was an observer dependent thing, but Dr. Gregory DeVore has made it quite objective. And once we track the endometrium, you can see that there are typical patterns of contractility which should be looked for. So the green is the diastolic line here. The gold here is the systolic, and you can see here the red is diastole and the green is the endocardium in systole. This is the left ventricle, this is the right ventricle, and typically in systole, all the margins move inwards except the basal segment of the interventricular septum, which moves in the opposite direction. So this is a normal fetal heart, and it's very, very important to get this animation when you're doing it. Similarly, in the right ventricle, in systole, you will see the endocardium moving inwards, except in the apical and mid portion of the interventricular septum, where it actually moves to the opposite side and then comes back in an inner fashion. Now, this is really important to establish the normalcy of the heart. Now, when we're looking at speckle tracking, and I'll show you a animation of that, there are various parameters that we can look at. And of course, we can look at myocardial velocity, ejection fraction, we can look at strain. And with fetal HQ, it has been simplified to look at the global sphericity index, look at the strain, fractional area change or fractional shortening. You can either look at a linear dimension or actually look at the area change. And you really don't have to do anything. The machine does everything, and it also gives you the ejection fraction of the left ventricle. Now, this was a landmark paper of his published in the year 2018, where he looked at fractional shortening, fractional area contraction, and a lot of other parameters and so basically, to understand again, as I told you earlier, what we see with M mode, we are looking at the change in diameter in diastole and systole. So in diastole, if the diameter increases, you are therefore getting decreased fractional shortening. As also if you have a condition which is causing increase in the contractility and decrease in the diameter in systole, then you will have increased fractional shortening. So basically, an increased diameter of the heart in diastole can cause a reduction in the fractional shortening. And that's what happens when we are dealing with conditions like diabetes or IUGR or volume overload or increased preload. There is increase in the diameter of the heart. And all these are basically looking at the same thing. So you can look at transverse contractility, you can look at longitudinal contractility. So you have fractional shortening in a longitudinal fashion. You have fractional shortening in a transverse diameter. So you don't have to shift your M mode in longitudinal transverse diameter. You just have to plot the 3 points, as we'll see, and this will give us fractional area shortening, fractional length shortening, and fractional transverse contractility. Now, you can see that this has been plotted between 20 and 40 weeks for both the ventricles, and he has also given us the normal charts and of various parameters relating to the BPD, head circumference, clinical gestational age, etc. I essentially use the clinical gestational age, and you can see that essentially it varies between 40 to 70 initially, and then it narrows down to about 40 to 60. So just as we were talking about the ejection fraction, it varies from 40 to 60. And not only can you see the global fractional shortening, but you can also see 24 segment. And as I said earlier, we really don't need to look at that. Segment 1 and 12 is representative. Of course, if there is segmental involvement, it will give you that idea also. So we did our first study about 2 years back, and I thank Aditi for helping me with that. We did about 10 studies to establish our normals. So this was the technique. You track a single cardiac cycle with an M mode cursor, and then you highlight one cardiac cycle from the beginning of diastole to the end of diastole, highlight the systolic peak, and then we measure do the speckle analysis. So we keep one cursor in the medial component of the AV valve annulus, the other component on the lateral aspect, one on the apex, and it will automatically then track the endocardium. Of course, it may sometimes go haywire, and then you need to alter it. You bring it along the endocardium and then do both diastolic and systolic analysis, as you can see here. And then you will get all the analysis automatically. So you will get the global sphericity index, you will get the global strain here, as you can see. This is a normal heart, and it's minus 15. The fractional area change is about 30%. Ejection fraction is 40%. You will also get fractional shortening in segment 1 and 12, both in the left ventricle and right ventricle, and all this by keeping 3 points on both the ventricles, and it takes about 2 minutes to do, and then the rest, of course, is to study. So when we studied a normal heart, again, we would get a strain of about -25, which fitted with what we were getting earlier. Ejection fraction 30 to 60%. This was an average mean. The global sphericity index was 1.26, and the fractional area change was about 49 to 50%, just like I showed you in the charts earlier. So this was the normal. Then we'll move to some abnormal cases here to give you an idea. This was the first 5 cases that we did. We did IUGR, we did congenital diaphragmatic hernia, we did pleural effusion, ductal constriction, and high drops. And in all these conditions, in majority of these conditions, these 3, of course, there was extrinsic compression of the heart. In IUGR, there was right ventricular hypertrophy and increased afterload, and so also in ductal constriction. And as a very primitive study, we looked at all these conditions put together, and we could see that the strain was dropping in these various conditions. So we had -15, -17, -14, -12 in ductal constriction. Ejection fraction was maintained quite till some time, except in this one case, it was dropping to quite a fair degree. But so ejection fraction was not altering till late. Fractional area change was also maintained. What was really showing a very high sensitivity was strain. That is the ability to change from diastole to systole, and therefore strain appears to be a very, very good marker, as also the fractional area change and fractional shortening as we look at. So I rely a lot on strain when we are looking at all these conditions. So let's look at some abnormal conditions now. This is a fetus with an inferior Vermian agenesis, and this was tracked from 22 weeks to 29 weeks. Severe IUGR, absent flow in the umbilical artery, and we can see that the strain was as low as -11%. Now, once we started speckle tracking, we could actually analyze different components of the heart. I'm sorry, when the video is seen as a recorded video, all the hearts appear slow, but that's not actually the case. I forgot to tell you that when we do speckle tracking, the most important component of speckle tracking is that we use the 2 to 9 or high frequency transducer, and we have to maintain a very high frame rate. So we go into a cardiac preset with a very narrow window, and you can see here the frame rate is more than 90 megahertz. So this is very, very important. But when we are recording these videos, they actually appear slow on the heart. But this is not what we see on the actual real-time image. So here was a case of IUGR with a very low fractional area change, and you can see the right ventricle was more severely affected, -4%, as compared to the left ventricle. Another fetus, and most importantly, the cartoon. This is important because this tells us that you are actually doing a good job. So it's very, very important to have the cartoon telling us how you are tracking the endocardium. Another fetus which is falling off in growth, severe growth restriction, absent diastolic flow, good flow in the ductus venosus, and there is a low CP ratio. And again, you can see the global strain is as low as -1.8 in the left ventricle vis-a-vis the right ventricle here, which has got a better strain. And fractional area change is also very, very low. And you can see here again, we are maintaining the cartoon of the left and the right ventricle. So it's very important that whenever you do this analysis, you have this. This is a late onset growth restriction. This was interesting because 34 weeks, only 1 week disparity, and the growth was dropping off. The CP ratio was less than 1, and you can see that here the cartoon again, and you can see the heart is getting enlarged, GSI is falling, and the ejection fraction was good, 40%. The strain was low, -10, -5.6. And exactly 1 week later, you see that the diastolic flow has worsened. She's 35 weeks. Reversal of flow in the aortic stenosis, so also increasing pulsatility in the ductus venosus. And here now you can see the difference in the measurements. The ejection fraction has also dropped from 39 to 22. The global strain has dropped from -10 to -3.8, and so also the fractional area contractility has dropped So in 1 week time, you can see so many changes over a period of time. This was another fetus presented at 38 weeks with prior scans normal. The AC was measuring less than the fifth centile, normal Leica, normal Dopplers, and you can see that the right ventricle is showing increased myocardial thickening with minimal pericardial effusion seen here. And otherwise, everything seemed all right. So good Dopplers, that is important. The ductus venosus was absolutely normal, but you can see the poor size of the right ventricle. And when we did the contractility studies, you can see that the global strain, even of the left ventricle, is as low as minus 6.29. Right ventricle was 3% strain, and ejection fraction is very, very poor. 38 weeks, normal Dopplers. This is really very important to see that sometimes even the Doppler may be normal, but yet you are seeing cardiac changes. We delivered this baby, and this baby is doing well at this moment of time. There was right ventricular hypertrophy on the postnatal echo, but otherwise the baby did well on delivery here. So, and this is brought out as we know that the high amount of stillbirth with normally grown babies, sometimes with normal Doppler or maybe a low CP ratio, these are the situations where we should look for the fetal heart. Although we have robust markers to look for late onset growth restriction in the form of uterine artery Doppler, CP ratio, the estimated fetal weight, what it does not account for is the fetal cardiovascular programming, which may start very early. So subtle cardiac dysfunction and cardiac remodeling are the factors which I think in the future will be very, very important at evaluating IUGR, both early onset and late onset. And here again, I would thank Dr. Gregory Devore for his humongous amount of work that he has done in these situations. And he has given us all these normal criteria. You can see that in FGR with abnormal CP ratio, the abnormal situations are more involving the right ventricle, as you can see here. Both, even with a small for gestational age baby, you have a large percentage of them showing fractional area change in the heart. So also in transverse contractility, you can see that the right ventricle is affected more than the left ventricle, and also longitudinal contractility, and all this data is available on his papers. This was an important contribution of his, where he said that perinatal death will directly be related to the left ventricular function, because as we know, as I showed you earlier, the right ventricular function is affected more than the left ventricular function. And if the left ventricle function gets affected, then as we said earlier, if there's mitral regurgitation or left ventricle failing, then we are definitely dealing with a high situation of perinatal death. And this is what he saw, that in the 24 segment transverse width analysis, where the left ventricle was dilating more than 95th centile, there was a higher incidence of fetal death. So not alone the contraction, but even the diameter increase caused increased perinatal death. And then, of course, the left ventricular ejection fraction. The worse the left ventricular ejection fraction, this is minus 5.6 Z-score, as compared to the babies which were alive, minus 1.6 Z-score, is also indicative of poor outcome. So ejection fraction and fractional shortening are important parameters. And this is from one of his talks. I clicked this picture where it is seen that all the babies, IUGR babies, which were alive and which made it, had good fractional shortening as compared to the poor fractional shortening in the left ventricle of the babies which died. So it's very, very important that left ventricular function be maintained. As I showed you also in my earliest case, where there was segmental ischemia involving the left ventricle and there was severe mitral and tricuspid regurgitation. Now let's look at some cardiac pathologies, left and right heart pathologies. Now this was a fetus with a very small left ventricle, hypoplastic left ventricle, almost appearing like a single AV valve, and we tracked this right ventricle, and you can see that the global strain here is as low as 2.9%. The fractional area change is also low. So sometimes when we're thinking of cardiac surgery or cardiac repair and giving counseling to these babies, then we need to probably look at these parameters, and these will be I think, the future of what we will be looking at. So look at aortic stenosis. Here, this is a fetus with critical aortic stenosis. And you can see we have tracked the endocardium here, and the strain is yet maintained. It's minus 14%. Not bad. So this is a situation where the ejection fraction is low because there is aortic stenosis, but there is good contractility yet maintained, and therefore we can either do an in utero repair of the aortic valve, or we can counsel that this, of course, if it is progressive condition, as you know, and with period of time, this may worsen. But at that point of time, this was good. Now, this is a case of rhabdomyoma causing compression of the left ventricular outflow tract. This was a twin pregnancy with both the fetus having rhabdomyoma, and you can see that there is contraction turbulence in the LVOT with marked increased flow due to the presence of the rhabdomyomas. And when we tracked there was good ejection fraction here, but the strain was very, very low here, minus 2.8 in the left ventricle, and worse for the right ventricle. So this is the right ventricular pathology. Now we are looking at right heart pathology. And this is, of course, tricuspid atresia with ventricular septal defects. And you can see that the left ventricle looks quite normal otherwise. So let's look at the strain. And you can see that here, predictably, we have the right ventricle chambers, which are small in size, and that is the left ventricle strain, which looks normal. But when you are actually looking at the strain, it is less. It is minus 7.17. Of course, the strain on the right side is minus 2%. The ejection fraction of the left ventricle is yet maintained. So you can probably consider some degree of repair because this fetus has presented, it is early actually, 18 weeks. So, I mean, essentially we can make some decisions there of termination if at all. So this is an interesting case of a twin pregnancy with the recipient twin showing pulmonary artery stenosis. There's marked increased flow velocity here. And we looked at you can see there's right heart chamber dilatation. There's also dilatation of the pulmonary artery here with bidirectional flow. And this is a right ventricular outflow obstruction. You can see the bidirectional flow here in a recipient of TDTS. And here again, if we see the global strain is good, minus 16. Right ventricular strain is also good. Fractional area is good, ejection fraction is good. So it's a very, very early right ventricular outflow obstruction which is developing in a TDTS, and probably if you do a laser correction, this may revert. So you could also have right ventricular overload in ductal constriction, and this was a fetus we monitored from 19 weeks to about 38 weeks. Here, the peak systolic velocity was more than 190. This was the right ventricle, which was dilated. As you can see in the subsequent pictures, this was the ductal constriction here, as you see here up here. And then we monitored the strain here. This is 19 weeks. This is about 38 weeks. And as you can see, over a period of time, the ejection fraction kept falling. The strain kept falling, the strain rate kept falling, and there was no hydrops which developed, but you can see the condition of the heart. The right ventricle is hypertrophied and dilated. At about 36 weeks, we delivered this process. We don't know the etiology in this particular situation. It started at 19 weeks, but the moment we delivered, the baby in a couple of weeks had a normal heart function. But you could see the whole progression of this changing pattern. Now, this was the pulmonary valve regurgitation or absent pulmonary valve syndrome. And here again, the right ventricular strain was poorly affected. It was almost as low as minus 3. So then we have increased cardiac output states. Like this is a vein of Galen malformation here, as you know, the heart looks normal, and you know this is about 36 weeks. This, in fact, is a case which I just did today, because the outcome of vein of Galen is essentially decided by the cardiac function. The moment there is cardiac dysfunction or hydrops, the prognosis becomes bad. So this is 36 weeks with good appearing heart, little bit dilated, but and very high flow shunt, you can see here. And when we did the cardiac function analysis, as you can see in a couple of minutes, we have the global strain is affected. It is low. It is 6.41 compared to the left ventricular strain, and right ventricle strain is yet maintained. The ejection fraction is 30%. So we are going to deliver her next week because there is already strain on the heart, and this is not a good sign. So this is going to be delivered next week because in postnatal correction is possible. This is a chorioangioma which presented at about 32, 33 weeks. The mother was Rh negative, father was Rh positive. But she had taken anti-D, but she has already started developing hydrops, and we just wanted 2 weeks. They refused a laser correction, which would have been the ideal way of correcting it, and we kept monitoring. We also gave a little top-up transfusion as the peak systolic velocity started rising, and then the strain improved, and at 34 weeks we delivered this fetus. So you can have sequential monitoring of these conditions, like in Rh, as you can see here, pre and post transfusion. We can see that the strain is pretty good, -26 with ejection fraction of 48. Also in early onset stage 1 TTTS, we can see that the strain can be affected. You can have low strain, especially in the recipient twin. This is the recipient twin. This is post-laser ablation. You can see that this is the recipient with myocardial hypertrophy, and this is the donor with good contractility and good myocardium. The ductus venosus was normal in both these conditions. But here, post-laser, you have altered strain in both the fetuses, markedly poor in the recipient. This was post-laser correction, -1.98 strain. So these are factors which we need to look into both before and after doing these major surgeries. Till now, we were not tracking the endocardium in arrhythmic states because of the high heart rate. But now with the possibility of HQ, we can monitor the strain even in these conditions, as you can see here in these conditions, where you can see that the strain is altered. It is very low, with, of course, expectedly poor ejection fraction because of the rapid heart rate. Now, that is to conclude that we do see a lot of additional parameters which we need to get into. Of course, there's a lot of research work that is involved, and thanks to Gregory, we have ultimately come to understand what we have been doing in 10 years. And just as we are understanding 2D speckle tracking on the horizon, is 3D speckle tracking that is there. So these are complex as conditions. As you can see here, the heart does not contract only in a longitudinal fraction, but in circumferential fraction and in rotational methods. And already on the horizon is 3D speckle tracking that we will be seeing in the future. So in conclusion, it's very, very important to evaluate cardiac function in various situations which can affect the heart. It may be an early marker of disease. It may be a late marker of disease. Very important to tell us when to intervene, when to deliver. In regular clinical fraction, we use essentially the myocardial performance index. It's a good marker, and it is gestational age independent. For diastolic function, we use the E to A ratio and the isometric relaxation time, which is gestational age dependent, and of course the ductus venosus. Tools which are of research, I did not talk much about tissue Doppler imaging because again it is Doppler angle dependent, and with speckle tracking already available, we really don't need to do tissue Doppler imaging. So speckle tracking really becomes the important tool which more than research now we are using in day-to-day practice. So myocardial deformation, as I said, is complex. Assessment of parameters like rotation, twist, and torsion is now feasible. Subclinical changes in myocardial performance can be detected. We can look at adaptation changes in IUGR, diabetes. In fact, there is a very interesting paper I read about early changes to diagnose coarctation before you can actually see the coarct, and I'm looking forward to doing something there. Of course, 3D is the future. So, in summary, we have multiple imaging modalities that are useful for looking at congenital and fetal cardiac defects and cardiac function. They provide a lot of insight into cardiac function in patients both with clinical and subclinical heart failure. And therefore, we must use these modalities to understand them, and so that we are ahead of the curve. And then when we are actually going to use them in clinical practice, we will be able to prevent morbidity, and of course, appropriate timing of intervention will be seen. We do have a lot of changes in fetal growth restriction, which may explain some of the unexplained fetal deaths that we see in the third trimester. As I said earlier, a small left ventricular area is good. If you have the left ventricle dilating and showing poor contractility, then we know that's a sign of pre-terminal fetal situation. So decreased LV ejection fraction, decreased fractional area contraction, or decreased fractional shortening in the LV are all ominous signs. So at this point, I thank you all for a patient hearing, and if there are questions, would love to address them. Zeenat?
Yeah, thank you very much, sir, for your detailed talk and showing us how that fetal cardiac evaluation can be done, and it will become easy with the newer technologies.
Yes.
It's a very new topic, and much understanding is required. So we have some small questions like, is for doing fetal HQ, do we need is it important, or it is necessary to have a basal view while doing the fetal HQs, or a apical or lateral view is?
So you need a good four-chamber view. As I said earlier, the apical and the basal view are not good to show because of the insonation dropouts that you see, and you will have dropouts in the endocardium. So always a lateral view is slightly better, or an oblique view. Just like in an apical four-chamber view, you will get a dropout and a false positive ventricular septal defect. Similarly, the endocardium may not be seen well in the apical four-chamber. The moment you turn to lateral four-chamber, you know that the interventricular septum is complete. Similarly, the endocardium will be well seen, and that's the best view to look at the endocardium, because basically you're tracking the endocardium.
Yeah. And so there's one question. They want to whether a fetus with bradycardia for 30 to 60 seconds, then normal heart rate, what to look for?
That can be normal. It can be a sinus bradycardia. Anything that is transient and comes back to normal is essentially normal. Of course, there should not be a conduction defect. There should not be a cardiac structural malformation, which like an AV conduction defect due to a transposition, or an AV valve abnormality, any structural abnormality which can alter the SA conduction. So anything that's transient and comes back to normal without alteration of the cardiac size and contractility is normal sinus bradycardia. But anything that is persistent and which with cardiac structural defects, or if there is a conduction block, like a 2:1 conduction block, then that is pathological.
And so the next question is whether, sir, while doing the fetal HQ, there is a in report the Z scores also will be there. So
Yes,
is it
yes.
necessary to follow the Z scores according to the effective fetal weight, or according to the BPD or any other
Yes.
parameters?
No, Z scores are important because, as you saw in the curve provided by Gregory, the fractional area changes over a period of gestation. So between 20 to 30 weeks, it decreases and then remains a plateau. So you can use z-scores for the fractional shortening. It's important to use the z-scores, but it comes automatically, or you don't have to calculate it. With HQ, it is such a wonderful technique. I'm so happy that so much work has gone into it, because all the parameters which in the first 10 years of my doing cardiac analysis, which I used to calculate on a computer, is done in 2 minutes by the HQ technology. So I think it's really worth its price.
Yeah, so thank you very much, sir. These are the questions we have got it today.
Okay.
Thanks for the wonderful talk and
Thank you. Thank you.